Our lecture is the cellular response to injury. Lecture 1. Here is the learning objectives. Normal cell function requires a balance between physiological demands and its structure and metabolic activity, and this is called homeostasis. More excessive physiological stress or pathological stimuli results either in adaptation or cell injury. So cell injury is defined as a morphological or functional changes or both as a result of variety of stresses the cell encountered. This diagram to show the normal cell in a homeostasis condition. So if stress or increased demand, the cell will be undergo adaptation, or if there is a failure of adaptation or pathological stimuli or injurious stimuli, cell respond by injury, or either reversible or irreversible or cell death. For example, we have a normal myocytes or the normal muscle fiber. If there is adaptation, the normal myocyte respond by increased the size or hypertrophy, or if there is a pathological stimuli or if failure of the adaptation, the cell injury occurs, either reversible or irreversible or cell death. So adaptation occurs when physiological or pathological stimuli induce a new but altered state that maintain cell viability. Adaptation includes hyperplasia, hypertrophy, atrophy, metaplasia, and we will discuss these conditions later. Now, what are the causes of cell injury? The most important and the most main cause in cell injury is the hypoxia. Hypoxia means decreased oxygen supply to the tissues and caused by ischemia. Ischemia means decreased blood supply to a tissue or an organ caused by arterial occlusion or arterial narrowing caused by atherosclerosis. Hypoxia also caused by inadequate oxygenation, for example, in cardiac and respiratory diseases leading to failure, or decreased oxygen carrying capacity in blood, as in cases of anemia and carbon monoxide poisoning. Other causes of cell injury include infectious agents like bacteria, viruses, fungi, and parasites, or physical agents as trauma, extremes of temperature, radiation, and electric shock, or maybe chemical agents and drugs such as strong acids, alkalis, poisons, and some therapeutic drugs. More causes of cell injury include immunological reaction, as in case of allergy or hypersensitivity and autoimmunity, nutritional imbalances, as in protein deficiency and lack of specific vitamins, and genetic derangements such as chromosomal alterations and gene mutation. The mechanisms of cell injury include impaired energy production or adenosine triphosphate depletion or ATP depletion, impaired cell membrane function, increased intracellular calcium, and accumulation of oxygen-free radicals. The first mechanism of cell injury is impaired energy production or ATP depletion, mainly caused by hypoxia and toxins. the decreased oxygen decreased energy production leads to failure of the sodium pump, so the sodium enter into the cell and potassium exit outside the cell, and this is followed by water entry, leading to accumulation of water inside the cells. Impaired ATP or impaired energy production leading to activation of anaerobic metabolism, so lactic acid production and accumulation inside the cell with increased osmotic load inside the cell. The second mechanism is impaired cell membrane function, and this is caused by direct damage by toxins, physical and chemical agents, by activation of the complement or production of the oxygen-free radicals. Impaired cell membrane function leads to loss of structural integrity of the cell and loss of the function with defects in the membrane permeability, leading to failure of the sodium pump and increased influx of the calcium inside the cell. The third mechanism is increased intracellular calcium. Normally, calcium is maintained at extremely low levels by membrane energy-dependent transport. Ischemia and toxins can cause calcium influx across plasma membrane, or the calcium can be released inside the cells from the mitochondria and endoplasmic reticulum. This is the illustration to show increased intracellular calcium leading to activation of certain cellular enzymes with their effects, as we will show in the next slide. Phospholipase, which leading to destruction of the membrane phospholipids or membrane destruction. Proteases, with the breakdown of the structural protein inside the cells. ATPase, increased the ATP depletion, and endonucleases, leading to chromatin fragmentation or DNA damage. The fourth mechanism of cell injury is the production of the oxygen-free radicals. Oxygen-free radicals are highly reactive, unstable oxygen molecules that can react with organic and inorganic materials, for example, superoxide and hydrogen peroxides. Increased production of oxygen-free radicals inside the cell caused by radiation, chemicals, and reduction oxidation reactions occurring during normal metabolism. The effects of increased oxygen-free radicals: damage to lipids, damage to cellular proteins, fragmentation of cellular DNA, and mitochondrial damage. Here there is a diagram to show oxygen-free radicals production or generation causes, and the cell injury by free radicals and neutralization of the free radicals, or no cell injury by certain mechanisms. This is a diagram to summarize the mechanisms of cell injury. The injurious or pathologic stimulus leading to decrease in ATP production. So there is a loss of energy-dependent cellular functions. Membrane damage, either the cell membrane or organelles membranes, leading to loss of the cellular contents as destruction of the plasma membrane, or enzymatic digestion of the cellular components as a result of lysosomal membrane damage and mitochondrial membrane damage, leading to decreased ATP production. Also, increased intracellular calcium and oxygen-free radicals lead to protein breakdown and DNA damage. The effects of cell injury depends on duration and the severity of the injury, type of the tissue, its state and adaptability or capability to adapt. Either two effects, either reversible cell injury or irreversible cell injury. Reversible cell injury is previously called degeneration, caused by mild injury of short duration, affects active parenchymatous cells or cells with high rate of metabolic activity. The morphological changes affect only the cytoplasm with sparing the nucleus. The morphological changes affect only the cytoplasm, the nucleus still intact. Includes cloudy swelling, hydropic swelling, and fatty change. The second effect of cell injury, it is the irreversible cell injury or cell death caused by severe injury or injury of long duration. Here there is the damage to the nucleus and includes necrosis and apoptosis. Lecture 2. Necrosis is defined as local death of group of cells within living bodies during life. On the other hand, somatic cell is the death of the tissues of the whole body. The morphological changes include gross changes and microscopic changes. Grossly, the necrotic tissue appears opaque and whitish or yellowish in color according to the type of the necrosis and surrounded by red areas due to inflammatory reaction and hyperemia. Hyperemia means increased blood supply to an organ or tissue. Microscopic picture, either in form of early changes, 1 to 3 hours, cells look normal, detected only by electron microscopy, from 6 to 8 hours, detected by light microscopy. We have nuclear changes and cytoplasmic changes. Nuclear changes is the best evidence of necrosis in form of pycnosis, which means decrease in the size of the nucleus with deeper staining. Karyoraxis means fragmentation of the nucleus, and karyolysis means disappearance or lysis of the nucleus. Cytoplasmic changes include swelling of the cells and which may be vacuolated, increased acidophilia with glassy appearance, fragmentation or lysis of cell membrane of the cells which become indistinct from each other and appear as homogeneous pink structured tissue. This is the section in a cardiac muscle with area of necrotic tissue in the middle of the field. The necrotic tissue or the necrotic cells appear homogeneous with increased eosinophilia with absence of the nuclei. On the other side, there is the healthy cells with intact nuclei. Types of necrosis include coagulative necrosis, which is the most common type, caused by sudden cut of blood supply or acute ischemia. Massive coagulative necrosis or large area of coagulative necrosis is called infarction. Common examples: myocardium, pulmonary, splenic, and renal infarctions. This is a gross and microscopic pictures of infarction of the kidney Grossly, the infarction shows pale color as compared to the normal surrounding color and surrounded by red zone of inflammation. Microscopically, the necrotic tissue appears homogeneous, structureless, pink, with absence of nuclei, which appear which appears on the left side of the picture, and the healthy tissue or healthy cells appear on the right side of the picture. The second type of necrosis is the liquefactive necrosis. In this type, the necrotic tissue undergoes softening due to action of hydrolytic enzymes and becomes rapidly liquefied and change into fluid or semi-fluid, occurs in suppurative inflammation or abscess, and the necrotic lesions of the brain and spinal cord. Here there is a gross section of the brain to show area of liquefactive necrosis. Also microscopically, the same area under light microscopy with microscopic changes of liquefactive necrosis. The third type of necrosis is the caseous necrosis. The necrotic tissue is changed into caseous material like casein of cheese by partial and slow liquefaction. The caseous material is yellow, soft, and friable, mainly seen in tuberculosis or tuberculous lesions and caused by allergic reaction to protein of tubercle bacilli. Here there is a gross section of the lung to show area of caseous material with the yellowish coloration with many defects due to friability of the caseous material. Microscopically, the caseous material appears homogeneous, pink, and structureless areas surrounded by healthy cells. The fourth type of necrosis is the fat necrosis, which includes two types, enzymatic and non-enzymatic or traumatic. Enzymatic occurs in acute hemorrhagic pancreatitis induced by action of lipase on the fat of mesentery, omentum, and abdominal organs. Lipase splits fat into glycerol and fatty acids. Glycerol is absorbed in the blood. Fatty acids deposit with the calcium as small, dull, opaque white patches. Traumatic fat necrosis occurs in breast and subcutaneous tissue. Usually there is a history of trauma. This is a gross picture of the omentum or fatty tissue inside the abdomen to show white patches of calcification due to deposition of the fatty acids and calcium. The fifth type of necrosis is the fibrinoid necrosis. This type of necrosis affects the wall of arteries and the arterioles and the kidney glomeruli. The necrotic material appears homogeneous bright pink material resembling the fibrin, so the name fibrinoid necrosis, seen in autoimmune diseases and malignant hypertension. Microscopic picture of an medium-sized artery with its wall homogeneous pink, structureless, resemble the fibrin. The fate of necrosis or the outcome of the necrotic tissue, either healing by regeneration of fibrosis or enlarged necrotic areas, there is a cyst formation, may be deposition of the calcium inside the necrotic material, what's called dystrophic calcification, or may be invasion by saprophytic bacteria leading to gangrene. The second type of irreversible cell injury is apoptosis. Apoptosis is defined as a form of cell death in which single cells are eliminated from the living tissue. The function of apoptosis is to eliminate unwanted cells selectively with minimal disturbance to surrounding cells and host. Mechanism of apoptosis: it is a programmed cell death through activation of tightly regulated internal suicide program. It is controlled by BCL2 protein family. It is occurred by activation of a group of enzymes called caseases. These enzymes result in destroying the nuclear membrane and activate DNAs, which degrade nuclear DNA or which destruct the nuclear DNA. Apoptosis seen in physiological and pathological conditions. Physiologically, during embryogenesis, for example, in the interdigital clefts removal, hormone-dependent involution of tissue, for example, endometrium during the menstrual cycle, cell deletion in proliferating cell population to maintain constant cell membrane, for example, the intestine and the skin, the normal cell turnover, deletion of potentially harmful autoreactive lymphocytes. Pathologically, in certain viral infection, for example, hepatitis, or to eliminate cells with damage of DNA by irradiation or cytotoxic drugs. Also, in certain malignant tumors. Lastly, in pathological atrophy in parenchymatous organs after duct obstruction, for example, pancreas. The morphological features of the apoptosis are shrinkage of cells, condensation of the nuclear chromatin, formation of apoptotic bodies by fragmentation of the cells and the nuclei, phagocytosis by adjacent healthy cells or macrophages. This is very important. It is not accompanied by inflammatory reaction. And this is a diagram to show the morphological features of apoptosis and also the necrosis. Here there is a microscopic picture of morphologic features of apoptosis. In the first microscopic picture on the top, there is a decrease in the size of the cells at the head of the arrow with condensation of the nucleus. In the two pictures in the inside in the bottom of the plate, there is leukemic cells, which is fragmented into many apoptotic bodies to the right side of the microscopic picture. Here there is a table for comparison between apoptosis and necrosis. So we have a cause, extent, cell membrane, cellular contents, morphological features, and the inflammatory response. This is the main feature to compare between the apoptosis and necrosis. Regarding the cause, apoptosis, physiological and pathological. For necrosis, it is a pathological only. The extent of the damage, apoptosis single cells, necrosis groups of cells. Cell membrane in apoptosis it is intact, while in necrosis is lost. The cellular contents intact in apoptosis undergo enzymatic digestion in necrosis. Here, morphological differences between the apoptosis and the necrosis. In the apoptosis, fragmentation and shrinkage of the cytoplasm, while in necrosis there is a pycnosis, karyolysis, and Cryorex's cytoplasm showed swollen and lysis, inflammatory response, no inflammatory response in apoptosis, while it is the frequent in necrosis.